Hello, everyone. My name is Dr. Marianne Gausche-Hill. I'm the medical director of the Los Angeles County Emergency Medical Services Agency, professor of clinical emergency medicine and pediatrics at the David Geffen School of Medicine. I'm also clinical faculty at Harbor-UCLA Medical Center in the departments of emergency medicine and pediatrics, and senior consultant for the EMS for Children Innovation and Improvement Center. And today I'm here to talk to you about a topic that we've all had to face with the increase in behavioral health conditions that we're seeing, especially in children. So the title of my talk is Safe Control of the Agitated Pediatric Patient. In regards to disclosures, as I said, I'm a senior consultant for the EMS for Children Innovation and Improvement Center. And this is funded through HRSA HHS, and you see the award there. And I need to state that the contents are those of myself and do not necessarily represent the official view of nor endorsement of any of the federal agencies, including HRSA, HHS, or the US government. So thanks. Here we go. So we're going to start out with some of the resources that are out there. And this is a great algorithm that can be incredibly helpful, along with additional resources that are at the site. And we'll have a QR code at the end so you can click onto it. But this is by the EIIC and TREC, which is Translating Emergency Knowledge for Kids. As you can see, the algorithm starts out in recognition of agitation, some of the initial strategies like de-escalation and calming, and then it moves to what is your assessment? What do you think is going on? And potential pharmacologic interventions, if indeed those are necessary. All right, let's move now to approach to the agitated patient. This is part of the algorithm from the EIIC and TREC. And so recognition and initial stabilization, I can tell you, recognition that somebody is agitated is fairly clear. They often pace, they might clench their teeth, their fists, they might be yelling, head banging, or defensive postures. And then obviously severe agitation is that they're combative or an imminent risk to self or others. Initial stabilization, we often do not do vital signs, but that's something, if the patient is agitated, but mildly so, you probably will be able to do that. And some of the things that you're going to be able to do are the 3 items below: manage the environment, behavioral de-escalation, and using calming interventions. Now, we'll get to need for physical restraint later, but just understand that if there's an imminent risk, the safety of the patient and the staff are paramount. And so that might necessitate initiating physical restraint or even pharmacologic interventions fairly early on in the encounter. So I mentioned some signs of agitation, but what about violence? History of violent behavior, you may have that in the medical record, and some of the medical records actually flag it, and so that's helpful. Substance abuse, alcohol, obviously these patients can be under the influence and therefore can be combative. Provocative behavior, getting into your space, backing out, almost in a threatening way with their body, that is something of concern. Loud or aggressive speech, screaming, use of profanity. In my experience, profanity, showing anger, again, pacing, tense posturing. And I mentioned, clenching the fist like that. And actually, that look that they have, which is staring to try to stare you down with the thought that this is a threat. These are scary circumstances, and I think some of the things that one can do is have another person in the room with you. You can say, validate the feelings. I see that you're angry. This may be very difficult for you. And I'm going to give you a minute to calm down, and then you can back out as needed. So these are some of the strategies that we do when we recognize that someone might have violent behavior. I mentioned applying restraint. So when would you do it? You do it when there's a potential or actual physical harm to healthcare staff or the environment, right? The other situation is imminent harm to the patient or others. And we've had, as an example, an adolescent attack their parent and start assaulting them in front of the healthcare staff. So again, getting physical restraint, we often have physical restraint teams. I'm going to cover that in just a second. So the data relatively is clear. I mentioned some data on violence in the ED, but what about some of the behavioral health emergencies? So 1 in 5 children, or 1 in 5 to 1 in 6, are essentially treated for behavioral health and mental health conditions. And up to 6% of children presenting to the ED for psychiatric care were placed in some form of physical restraint, such as leather restraints. There's no real great randomized trials on the use of medications for pharmacologic intervention. I just want to say we don't say chemical restraint anymore. It's really pharmacologic interventions that can help reduce the impact of their agitation. And I think that's really critical to think about it that way. So I mentioned restraint teams, and there's really some science here and definitely an organized approach to putting someone in restraints. There's generally a restraint leader that sets up the ground rules. And once we call them code gold at our facility, once that team has been contacted, there's no more negotiating with the patient. If you remain calm, we won't do this to you. That's already been explained to them. So the restraint team is there. They give very definite, concise, controlled discussion. I need you to lay down and I need you to be still. And then the team moves in, all right? And the key thing is, and these team members at our facility at Harvard UCLA, where we're clinically, they're very experienced. They're not bringing in stethoscopes or pins or anything like that. They know and they're ready. The leader will speak to the patient, as I said, why the restraint is needed and what they need to do. And then again, the team moves in and initiates the restraint. There's one on every limb. So a la 4 people and the leader. So you need a minimum of 5 people on a restraint team. I think utilizing the resources such as the EMS for Children Innovation and Improvement Center and TREC tool. Here's a QR code that's going to link you to the resources that you need, that EIIC algorithm, which I think is really helpful, and the medication table. I personally want to acknowledge Drs. Patrick Kelly and Eric Chung for their assistance with me as I developed this talk for you. And obviously the wonderful expertise of the EMS for Children Innovation Improvement Center and TREC for them really coming together to collaborate on these resources that will help you take better care of your patients. Thanks for listening. You can email me at mgausche-hill@dhs.lacounty.gov or on Twitter at mgausche-hill. Thanks so much.